Now I'm going to switch gears real quick to talk about oligoprogression. What is oligoprogression? It's patients who have received frontline therapy and then their disease progresses, but their disease progresses only in a limited number of sites. And some people, and so at the end of the day, as we said, all patients with TKS will eventually progress. Hopefully, it's from a long time out. Some will have oligoprogression, meaning to a few sites of disease. And so the question was with this group that was published back in 2012 is that they decided to radiate or consider radiation for those patients that had oligoprogressive disease. And so their hypothesis was that the patients that had progressive disease in a limited fashion gets radiation, that they could have an improved progression-free survival. And that was kind of what they showed in this study. So again, some evidence to suggest maybe not in the upfront setting or the consolidation setting, but after you've progressed on a frontline therapy, but in an progressive condition, there still may be benefits from local therapy. We also took this kind of role. Can we add SBRT to patients that have progressed on frontline systemic therapy, in this case, erlotinib? So we actually treated patients who had failed erlotinib, who had 6 or fewer discrete lesions with SBRT, continued the patients on erlotinib to see if it controlled disease elsewhere. And these are just some of the characteristics. But at the end of the day, we found a PFS and an OS that was quite good compared to historical patients that were just on erlotinib, who had failed 1, 2, or even 3 lines of therapy. So again, it gives us hope that these patients who may get local therapy in a selected patient population will do really well. And it actually changed the patterns of failure. The addition of radiation stopped patients from failing first in original sites of disease. What it did was it delayed failures, and when failures occurred, it was in new sites of disease, not the original sites of disease. And so that's really what we wanted to see. Unfortunately, very interestingly enough, this study preceded the era of widespread mutational testing. None of the patients that we tested had EGFR mutations. So in many ways, and then back then, remember, EGFR inhibitors were thought to be of help in the wild type EGFR setting. And now, of course, we know that that's not to be the case. But in any event, this study suggested that SBRT, again, in an oligoprogressive condition could be helpful. So there are some randomized studies. This one is Stop Non-Small Cell Lung Cancer for Oligoprogressive Disease. That includes targeted therapies. This is HALT. It's in Europe. They are finished accrual, and we look forward to seeing the results of both of those studies, these 2 randomized studies. And so at Memorial Sloan Kettering, they recently completed a study using, again, a radiation in an oligoprogressive state to look to see if there was a benefit in the use of local therapy. And again, the idea is that we shrink the disease, but some patients will start failing and progressing in original sites of disease. Can we use local therapy? So this study included patients that had EGFR mutations that were on osimertinib. And they basically either received radiation to the local disease that progressed or did not receive radiation. And as you can see here, the patients that received radiation, the curve in red, they had a significant improvement in progression-free survival compared to the patients that did not receive radiation to their oligoprogressive disease. So again, a very interesting and positive signal in this space. But with the last few minutes, I'm going to basically say that we haven't done enough. We haven't done enough to understand when to use local therapy to better personalize our treatments for all of you. And the reason is because we failed to predict disease trajectories. All of our previous studies were basically saying we're defining oligoprogressive disease or 3 or 5 or fewer lesions. We're describing oligometastatic disease as 3 or 5 or fewer lesions. That number is a snapshot in time. It is not giving us a dynamic understanding of disease trajectories.